Here's the honest truth. Anesthesia isn't sleep, and it definitely isn't unconsciousness the way you imagine it. It's actually a carefully staged shutdown of your brain's most important networks, with each layer designed to block pain, awareness, and memory in specific ways. And in 2025, anesthesiologists watch dozens of physiological variables at once using specialized monitors. At minimum, that includes pulse oximetry for oxygen, capnography for breathing, ECG for heart rhythm, non-invasive blood pressure, temperature probes, neuromuscular monitors, and even processed EEG to track brain activity. Far more is happening than just checking your pulse. Over the next few minutes, you'll see how drugs silence your brain, what your anesthesiologist is watching, and why the whole process is much safer than most people think. But before we get into the science, let's clear up one of the most famous misconceptions about going under. Why counting backwards is just a party trick. If you've ever been told to count backward from 10 as anesthesia begins, you might think that's how consciousness gets switched off. The reality is that the numbers aren't doing anything to your brain at all. That counting is just a small distraction, something simple for you to focus on in the last clear moments before the drugs take effect. The real shift comes not from reaching zero, but from the chemistry already moving through your system. In modern practice, induction of anesthesia happens fast. If you're given an intravenous drug like propofol, it typically takes effect within seconds to under a minute. By the time you've spoken a few numbers, molecules are already binding to key receptors in your nervous system and slowing them down. With mask-based inhalation, the timeline stretches a little longer. The gases need a couple of minutes to build up to effective levels in your brain. Either way, the transition has very little to do with finishing a countdown. A lot of people who go under don't even remember starting to count. That's because anesthetics interfere with the hippocampus almost immediately, disrupting the circuits that encode short-term events into memory. From your perspective, it feels like the moment simply vanishes. You may recall a nurse asking you to begin, but the next thing you know, it's later in the recovery room. Memory does not gracefully fade, it simply stops recording. So what's happening beneath the surface? The simplest explanation is that anesthetic drugs change how brain cells communicate. Some IV medications enhance inhibitory GABA activity, while others block excitatory NMDA signaling. Both affects quiet neural conversations, reducing the ability of networks to synchronize in the way consciousness depends on. A useful way to think of it is like traffic lights across a city suddenly switching to red at the same time. Cars remain on the road, but no one can go anywhere. Mental traffic stalls and awareness disappears. This quirk also explains why a clever line rehearsed beforehand almost never survives into memory. Plenty of patients plan something funny to say before they go under, but the drugs get ahead of them. As soon as the hippocampus shuts down, sentences trail off or never get stored. Anything said in those moments is usually forgotten, which is why people often debate later what the last words really were. In most cases, there was nothing coherent enough to remember. Even though counting doesn't cause loss of consciousness, the ritual has stuck around. Historically, before fast-acting agents were available, it gave anesthesiologists a rough gauge of how quickly sedation was progressing. Today, its function is mainly psychological. Repeating numbers provides a simple focus for patients, especially children, and helps take the edge off anxiety. That's not trivial. Stress itself ramps up heart rate and adrenaline, and a repetitive task can ease that sympathetic surge. For the anesthesiologist, those spoken numbers can still offer useful feedback. A child who suddenly stops mid-sequence signals the exact moment a drug begins working. Even adults sometimes trail off mid-sentence because the shutdown is so abrupt. One instant you're speaking normally, the next there's silence. To outside observers, this is routine, but for the patient, there's no recollection because the process disconnects awareness rather than allowing time for reflection. From the inside, this process is stranger still. The human brain can't register the steps of its own shutdown. We expect to feel ourselves slipping away, but that expectation comes from experiences like falling asleep. With anesthesia, one moment is ordinary and the next is gone with no sensation of the transition. Whether you're halfway through a sentence or a number, awareness ends before you can notice it. It's worth addressing one fear that sometimes surfaces: the rare reports of people waking during surgery but unable to move. This phenomenon, called intraoperative awareness with paralysis, is real but exceptionally uncommon in modern practice. Careful dosing, continuous monitoring of multiple physiological signs, and use of drugs that combine unconsciousness with amnesia mean that the overwhelming majority of patients never experience anything like it. For trained providers, preventing awareness is a critical part of the process. The speed and efficiency of induction often surprise patients. Some imagine a gradual descent into unconsciousness, like drifting off in a darkened room. Instead, anesthesia is more abrupt, a sharp cut in the timeline. One moment you're present, the next it's hours later, with no perception of what bridged the gap. Hollywood's drawn-out countdown scenes make for drama, but they misrepresent the immediacy of the shift. By the time the drugs reach their targets, multiple layers of function are silenced in rapid succession. Circuits that support consciousness lose integration, memory encoding networks are disabled, and pain signals are suppressed before they reach awareness. The end result is not a slow merger into sleep, but a precise, engineered blackout. The counting, then, is just a courtesy gesture, something human and familiar at the very edge of awareness. Understanding that anesthesia acts so quickly helps put some common worries into perspective. People often imagine that saying something embarrassing will haunt them later, but in truth, there's almost no chance their words were stored in memory or even completed. The real unknown isn't what you might blurt out. It's the remarkable biology guiding that instantaneous leap from full wakefulness to blackout. And it's this same process that feeds into a much bigger worry many people have yet to shake. Not what might happen during those blanked out minutes, but what happens on the other end of them. Once the drugs have switched everything off so completely, some can't help but ask what guarantees they'll wake up again. That lingering anxiety leads directly to one of the most common questions patients still bring into the operating room. The 2025 safety numbers nobody expects. What often catches people off guard is just how safe anesthesia has become in 2025. While many patients imagine the worst when they think about going under, the actual numbers tell a very different story. The most reliable modern data show that deaths attributable solely to anesthesia itself now fall in the range of roughly 1 in 100,000 to 1 in 300,000 anesthetics for otherwise healthy patients. For context, the Anesthesia Patient Safety Foundation consistently reports that mortality today is dramatically lower than what was seen a generation or two ago. In plain terms, the risk is far smaller than everyday hazards most of us accept without thought, such as the drive to the hospital. That improvement isn't by chance. It arises from decades of systematic changes. In the mid-20th century, anesthesia complications were far more common, often because the available drugs were long-acting or unpredictable, and because airway problems or hidden medical issues could spiral quickly into crisis. Modern anesthesia relies on short-acting agents that wear off quickly when the infusion stops, advanced airway tools that make maintaining breathing far safer, and standardized monitoring that every anesthesiologist must use by mandate. Pulse oximetry to track oxygen, capnography to track exhaled carbon dioxide, continuous ECG, automated blood pressure, and temperature probes are part of the minimum standard almost universally. Those monitors, combined with mandatory checklists and regular simulation training, have pushed anesthesia safety into a realm few thought possible decades ago. This progress is why anesthesia complications that were once a genuine risk now stand out as outliers. Most of what patients experience after routine anesthesia falls into the category of minor annoyances rather than life-threatening events. Nausea, grogginess, sore throat from a breathing tube, or muscle aches from certain medications are far more common than any serious emergency. They may be unpleasant for a few hours, but they are not dangerous and usually clear quickly. That reality contrasts sharply with the lingering fear of never waking up, which for the overwhelming majority of patients is statistically vanishingly small. Another factor patients may not always recognize is the role of training. Anesthesiologists undergo years of advanced medical education after medical school, residency, board examinations, and ongoing certification, focused specifically on anticipating and managing both ordinary and rare complications. They rehearse scenarios that most will never encounter in a real case, because preparation is the safeguard. On top of that, high-fidelity simulators and standardized crisis protocols allow providers to act decisively even in situations that arise once in a career. Just like aviation, where pilots train for emergencies they may never see, anesthesia emphasizes preparedness for every outcome. In turn, redundancy across drugs, monitors, and emergency equipment ensures that no single failure quickly leads to catastrophe. Safety also benefits from a cultural shift in medicine over the past several decades. The operating room today is designed for team communication where every person, from anesthesiologist to circulating nurse, is encouraged to point out concerns early. Checklists are applied before every induction, much like a pre-flight procedure, confirming correct drugs, available reversal agents, and patient-specific detail. This standardization matters. It minimizes human error, which historically was one of the main contributors to anesthesia mishaps. Even with all those systems in place, the biggest guarantee of safety often comes from tailoring the anesthetic plan to the individual person. In the past, dosing guidelines leaned heavily on weight and general estimates. By 2025, anesthesiology has shifted toward more personalized strategies. Patient age, cardiovascular health, pulmonary status, obesity, presence of sleep apnea, kidney or liver function, and even response patterns tracked through electronic health records all shape what drugs are chosen and at what doses. Machine learning models are increasingly assisting anesthesiologists in predicting which patients might benefit from specific airway tools or adjusted induction techniques. The aim is not only comfort, but precision that avoids both under- and overdosing while keeping vital functions stable. From the patient's perspective, this translates to reassurance, but also responsibility. While the general risk in 2025 remains exceptionally low, individual medical conditions still matter. That's why the pre-anesthesia consultation is not just a formality. Talking openly with your anesthesiologist about factors such as asthma, heart disease, sleep apnea, diabetes, smoking, or even regular use of over-the-counter supplements gives them the information needed to fine-tune the plan. For viewers, this is the single most practical step you can take. Be transparent in pre-op discussions so your anesthesiologist can anticipate potential difficulties long before induction begins. When framed this way, the safety of anesthesia becomes less abstract. Instead of thinking of it as handing over the keys to your consciousness with no guarantees, it helps to view it as entering a system built on redundancy, constant surveillance, and individualized planning. The nightmare scenarios people imagined made sense when monitoring was crude and drug options were blunt tools. Today, most anesthetics proceed uneventfully, and the rare emergencies that do occur are typically recognized and managed before harm results. Also striking to compare what the data suggests now versus half a century ago. In the 1940s and 50s, anesthesia-related mortality was measured in the range of 1 in 1,500 to 1 in 10,000. That meant every anesthesiologist could expect to witness multiple serious events across a career. Fast forward to today's 1 in 100,000 to 1 in 300,000 for healthy cases, and you see how drastically the environment has changed. The shift stems not from a single breakthrough, but from the steady layering of small, systematic improvements, monitor alarms, shorter half-life drugs, shoulder-to-shoulder collaboration. Each advancement narrowed the margin for error until modern anesthesia began to look less like high-stakes gambling and more like controlled precision. Still, numbers alone don't completely soothe the unease. There's a psychological gap between understanding something is safe and feeling that safety in your bones. Few people get nervous stepping into their car, even though the actuarial odds are worse. Yet lying on an operating table, surrounded by unfamiliar machines, taps into a primal fear, the inability to steer your own body. What helps close that gap is reframing what's happening. You're not abandoned during unconsciousness. You're monitored in ways that exceed everyday experience. Every breath, every heartbeat, every shift in brain activity is tracked, interpreted, and adjusted for continuously. The irony of all this is that one of the most intimidating aspects of surgery is in fact the safest. Procedures themselves carry uncertainty depending on the site, the disease, and the repair. But the anesthesia that makes operations possible is designed to insulate you from pain, stress, and trauma. The field's relentless emphasis on analysis after every rare incident ensures that safety only grows stronger over time. When you step away from the fear and look at the system as it operates today, the bigger question is, will I ever wake up? But rather, how exactly does anesthesia shut down the brain without shutting down the whole person? And that question leads directly into the surprising way anesthetics actually interact with the brain's networks. which is far more complex than flipping a single on-off switch. The brain shutdown isn't all or nothing. Most people imagine that anesthesia sweeps over the brain like someone pulling a master switch. One moment there's full awareness, and the next there's nothing, an instant blackout. It's a simple image, shaped by movies and old explanations, but it's not what actually happens. Instead, anesthesia is more like closing down apps on a device, one program at a time. Memory, awareness, movement, and pain each powered down in a sequence, carefully managed by drugs designed to target different receptors. The system never shuts off completely. Basic life functions remain running while the conscious parts are suspended. That phone app view helps clarify what's really going on. No matter how many apps you close, the phone itself is still on, still maintaining core processes. In anesthesia, the vital systems that govern circulation, temperature regulation, and reflex survival functions continue to operate. What gets suppressed are the higher programs, the complex networks that create the experience of consciousness. Which app closes first depends on the drugs chosen. Some agents act fast on the hippocampus, where memory formation takes place. Others target GABA or NMDA receptors, quieting the cortex and disrupting the synchronized communication needed for awareness. Opioids, often added to the mix, work on opioid receptors to block pain signaling before it ever reaches full perception. Clinically, once those drugs reach effective concentrations, resistance is not meaningful. It's a biochemical effect that overrides voluntary effort, but one that fully reverses as the drugs wear off. Memory almost always goes down first. Patients may still be talking, but their brain isn't filing new information away. From their perspective, time simply jumps forward. Next, the sense of awareness dissolves as cortical networks lose the ability to coordinate activity across brain regions. The orchestra of neurons is still playing, but without synchronization, there's no experience of the music. At that point, consciousness is absent no matter what the body may look like from the outside. Movement and reflexes come after. If anesthesia only erased awareness, the body could still twitch or resist surgical stimulation, which would make operations dangerous. To prevent this, anesthetics depress the spinal cord's motor pathways, and in many cases, neuromuscular blockers are added to guarantee immobility. These drugs don't operate on memory or awareness at all. They work peripherally, silencing the skeletal muscles. It ensures that even reflex responses never reach the surface. The process is not one of feeling and failing to move. It's simply the absence of that motor communication altogether. Pain control closes the loop. Pain is always the product of signals climbing from peripheral nerves to the spinal cord and on up to cortical centers. General anesthesia blocks that pathway at multiple levels. Opioids intercept the messages at the receptor. Inhaled and intravenous agents suppress spinal transmission. Sedatives dull the brain's response at the top of the chain. The signals themselves may continue firing in the nerves, but they arrive at no functional destination. In effect, the pain app is closed, and there's no conscious system left to notice unfelt messages. This layering explains why wake-up doesn't feel symmetrical to going under. As drugs wear off, not every system resurfaces at the same pace. Reflexes may return first, so you can move before your mind is fully aware. Memory can lag, so you may already be awake before you start recording new experiences. Awareness often feels like it dawns abruptly, producing that uncanny break where the next moment you recognize, you're already in the recovery unit. Just as the shutdown is staggered, the reboot process comes back online in steps, because these transitions involve different receptor systems. GABA for sedation, NMDA for blocking excitation, opioid receptors for pain, and neuromuscular junctions for movement. It's possible to fine-tune the balance. An anesthesiologist can emphasize stronger pain control while keeping sedative levels lighter, as in some obstetric cases, or induce deep unconsciousness paired with full muscle relaxation for more invasive surgery. The sequence is flexible, and while memory and awareness usually go early, the order of other changes depends on the combination used. Another important distinction is what stays active throughout. The autonomic centers in the brainstem that regulate heartbeat and basic breathing rhythms remain intact. Under controlled conditions, ventilation is often supported and monitored, but those core circuits never fully turn off. That's why anesthesia is not like removing the battery from a device. It's like suspending every optional program but leaving the operating system running. From a patient's point of view, the result is an instant blackout. But from the neurobiological side, it's a sequence of silenced functions linked to measured concentrations of drugs in the body. This is why induction is so reliable and recovery just as predictable. The shutdown is not driven by will, fatigue, or psychology. It's chemistry acting precisely at receptor sites. When the infusion stops or the gases wash out, those effects fade and the system reassembles itself. Framing it this way also helps explain why anesthesia is safe even though it seems mysterious. Nothing is erased or permanently damaged. The functions you rely on to feel, move, and remember are only placed in suspension. Once the drugs leave your system, those circuits resume activity as if they were paused. It's that reversible character, selective inhibition without destruction, that defines modern anesthesia. Misunderstanding it as a total blackout adds unnecessary fear. The truth is that your brain under anesthesia is active, just not integrated in the way necessary for experience. Each component, memory, awareness, movement, and pain, is muted in its own window of time, sometimes overlapping, sometimes staggered, but collectively producing the seamless gap you perceive. By staging this shutdown in layers, anesthesiologists create the illusion of instant disappearance while keeping the essential background running. And while that illusion has often been compared to sleep, it is not the same. Sleep restores networks, rotates through cycles, and maintains rhythms designed for recovery. Anesthesia, by contrast, disables connections instead of nurturing them. To an observer, the unconsciousness may resemble slumber, but the brainwaves tell a very different story. That difference, and why it matters, is the next crucial piece of understanding. The real science behind the sleep that isn't sleep. Every patient has heard the same phrase before surgery. Someone leans close and says, "We'll put you to sleep." It's meant to calm nerves, but scientifically it isn't accurate. Anesthesia is not sleep. It only seems like it because you enter a gap in awareness. Real sleep is an active biological process with repeating cycles, while anesthesia is a pharmacologically induced, reversible state that suspends consciousness without restoring or repairing the brain. Understanding why that distinction matters requires looking closely at what each state actually does. During natural sleep, your brain moves through structured stages in predictable cycles. Non-REM phases support tissue repair and general recovery, while REM phases are critical for processing emotions and consolidating experiences into memory. EEG recordings show recognizable rhythms, the constant rise and fall of brainwave frequencies that mark healthy rest. Even though you're unaware of the outside world, your brain remains active, building connections, pruning unnecessary ones, and replaying patterns that encode learning. That is why good sleep leaves you refreshed, stabilized in mood, and sharper in cognition. Anesthesia shows none of these features. Under general anesthesia, large-scale brain networks lose the ability to communicate with one another. Instead of rhythmic cycling, activity either flattens into slow, disrupted patterns or breaks into bursts unrelated to normal sleep physiology. Functional MRI and EEG evidence confirm these differences. Areas of the cortex that usually coordinate with the thalamus fail to link, and the normal balance of phase-locked brainwaves disappear. Put simply, anesthesia doesn't let the brain work, it pulls the plug on network integration. The brain doesn't process memories, it doesn't regulate itself through cycles, and it doesn't come out stronger on the other side. This explains why anesthesia does not serve restorative purposes. Sleep deprivation triggers recovery periods. Miss a night and your body drives you into longer, deeper stages the next evening. After anesthesia, no rebound occurs. There's no prolonged REM, no catch-up, slow wave deepening, because the brain doesn't interpret anesthesia as sleep at all. You were disconnected, not repaired. The haziness and disorientation people feel upon waking is not grogginess from oversleep. It reflects the chemistry wearing off and networks struggling to resynchronize after being held apart. One of the clearest functional differences lies in memory. During sleep, the hippocampus actively replays daily experiences, transferring them into long-term storage. Under anesthesia, the hippocampus stops encoding almost immediately. That's why most patients recall nothing from the operating room, even if they were technically conscious for a few early instants. The blackout isn't passive forgetting. It's the inability of the memory system to write anything down in the first place. Sleep enhances memory consolidation. Anesthesia halts it outright. So why doesn't that disruption damage the brain permanently? The answer is reversibility. Anesthetic drugs alter receptor activity in ways that prevent large-scale coordination, but only for as long as the drugs are present. Once levels fall, the networks can reconnect. Unlike chronic sleep deprivation, which accumulates biological harm, anesthetic exposure ends cleanly. It suspends cognitive function for hours, but because it is carefully controlled, the effects fade predictably with metabolism. That's why anesthesia can be repeated safely across millions of surgeries worldwide. In practice, this distinction shows up after operations. Even after a long nap under anesthesia, patients don't wake with the same clarity and energy that follow true sleep. Instead, they may feel foggy, clumsy, or temporarily confused. Studies using EEG show that the brain doesn't immediately snap back into coordinated rhythms. Different regions reconnect at slightly different rates, creating a staggered return to normal consciousness. What patients describe as coming out of a fog reflects those uneven reconnections more than any restful state. For anesthesiologists, these differences matter clinically. Modern monitoring doesn't treat anesthesia as stages of sleep, but as measurable levels of disconnection. Devices that process EEG now produce simplified depth of anesthesia indices. These numbers don't grade how deeply asleep you are, they reflect how reduced your brain's connectivity has become. External stimulation during natural sleep might rouse you with a sharp sound. Under anesthesia, the same sound fails to reach conscious perception because the networks that would pass the signal forward are offline. Information reaches sensory nerves but stops there, never assembling into experience. A useful way to appreciate the contrast is by thinking about outcomes. Sleep is essential for survival. Without it, immune function declines, mood collapses, and memory fails. Anesthesia provides none of those benefits. Its purpose is utilitarian, to erase awareness, immobilize the body, and block pain during surgery. You leave the operating room alive and unharmed by the procedure, something impossible without anesthesia. But you don't leave more rested, restored, or sharper than before. The healing that happens afterward comes from the surgery and from the return to natural sleep in recovery, not from the anesthetic itself. Research from Harvard, MIT, and other neuroscience centers in recent years has emphasized this point with striking imaging evidence. Sleep shows cycles of synchronized slow waves and bursts, while anesthesia strips those cycles away, replacing them with flattened signals or abnormal oscillations that never rotate through healthy phases. The bottom line is simple. Anesthesia is not an evolutionary rest state, but a pharmacological suspension. The two may feel similar only because both involve missing a stretch of time. Biologically, they are worlds apart. This understanding also helps explain why the language of putting you to sleep persists. It's easier to say, and it reduces anxiety before surgery, even if it misleads. Patients rarely want to hear, "We're about to induce a chemical state that shuts down awareness of everything," even though that's the truer description. For reassurance, the term sleep sticks, but it hides the fact that no one is guiding you through dream cycles or natural rest. What's happening is engineered silence, not nurturing restoration. So the best way to think of anesthesia is as a controllable blackout. It is reversible, predictable, and medically useful. It is not something your brain enters voluntarily or something you can practice on your own. It is induced, sustained, and terminated entirely by drugs designed for precision. Understanding this clears up one of the biggest misconceptions patients carry in. Anesthesia may feel like drifting off to sleep, but it is not. It is an absence, a void in function with no parallel in your daily biology. And that distinction leads to an important takeaway. Don't expect anesthesia to give you the benefits of real sleep. It does not restore, it does not help cognition, and it does not build memory. What it does is block awareness long enough for surgeons to work safely and for you to avoid trauma. It's not sleep, it's a tool, and a powerful one. A tool that only works because someone is keeping it tightly controlled from start to finish. The anesthesiologist is basically your pilot. There's a persistent misconception about anesthesiologists that they show up at the start of surgery, give you drugs to knock you out, then step back while the real work happens. The reality is completely different. Keeping someone safely anesthetized is not a one-time task. It's an ongoing process that requires active management every second. Think less about flipping a switch and more about guiding a moving system that never sits still. If anesthesia were left to run on autopilot with a fixed dose, the results would be dangerous almost immediately. Human physiology changes constantly. Blood pressure rises and falls, breathing varies, fluids shift, and metabolic demands fluctuate. Add surgery to the mix, and the stresses multiply. Incisions trigger reflex responses, bleeding alters circulation, mechanical ventilation changes gas level. Without constant adjustment, patients would swing between too little anesthesia, with the risk of waking, and too much, with the risk of crashing vital functions. That razor-thin balance depends entirely on continuous oversight. That oversight takes place at the head of the operating table, where the anesthesiologist remains throughout the procedure. In 2025, they monitor a wall of live data: heart rhythm, blood pressure, oxygenation, ventilation, carbon dioxide concentration, and temperature. Modern standards require these to be tracked without interruption in every anesthetic. On top of that, anesthesiologists manage airway devices, ventilators, IV infusions, and inhaled gases, while also watching processed EEG to gauge brain activity. Every number is meaningful because it dictates the next adjustment. The role is not passive, it's active control of a dynamic system. Brain activity monitoring illustrates how the job has shifted. Instead of relying only on indirect signs like blood pressure changes or reflexes, EEG-based indices now provide a real-time measure of conscious state. Patients don't all respond alike. Two people of similar size can need very different doses. With EEG-based depth monitoring, those doses become precise rather than approximate. Each drug level is tuned so the patient remains unconscious but not overly suppressed, awake enough to maintain stable physiology yet unaware of the surgery. This constant vigilance is why comparing anesthesiologists to pilots works so well. Airplanes don't fly straight if you simply set the controls and walk away. Wind, altitude, and turbulence force continuous corrections. The same holds true in anesthesia. Your body is never perfectly stable. The pilot's role is not just takeoff and landing, but steering through the whole journey. Just like turbulence, surgical stress may cause sudden dips or surges in blood pressure or oxygen. The anesthesiologist is always correcting those shifts before they widen into danger. The most obvious example of this is breathing. Under general anesthesia, many patients cannot protect their own airway or keep gas exchange adequate. The anesthesiologist places a breathing tube and connects the patient to a ventilator. But putting someone on a ventilator is just the beginning. Oxygen levels must be optimized, carbon dioxide carefully managed, and the pressures controlled to avoid lung injury. Settings get adjusted minute by minute in response to physiology and surgical changes. Without that monitoring and adjustment, gas levels can drift dangerously without the patient ever signaling distress. Circulation offers another clear example. Blood pressure is not constant, and during surgery it can rise or fall in seconds. A severe drop can starve vital organs, while a surge can increase surgical bleeding. Anesthesiologists monitor every beat on the ECG, respond with fluids, fine-tune anesthetic depth, or administer vasoactive drugs as needed. Their decisions prevent swings that would otherwise jeopardize both safety and the surgeon's ability to operate in a stable field. These ongoing corrections highlight an important reality about technology. Machines provide vital data, but they don't replace human judgment. Automated systems that attempt closed-loop control of anesthesia exist in research settings, and AI models already assist with predicting patient needs, but none eliminate the need for a physician watching and deciding in real time. Anesthesiologists integrate streams of information and act with nuance that machines cannot. Automation is a tool, not a substitute. The decision-making remains a human responsibility. Temperature control is one of the often overlooked tasks. Anesthetic drugs reduce natural body regulation, leaving patients prone to cooling in the cold surgical environment. Hypothermia can prolong recovery and impair clotting. It falls to the anesthesiologist to use forced air warmers, warmed IV fluids, and room adjustments to keep temperature within safe limits, even though the patient is completely unaware of the risk. Perhaps the most underappreciated part of anesthesia is that getting patients safely out of it requires as much planning as putting them under. Emergence is not just stopping medications, it's a planned descent. Anesthesiologists begin preparing long before the end of surgery, tapering drugs, washing out gases, and ensuring the patient resumes stable breathing. Airway devices stay in place until the patient demonstrates adequate function. Done well, the transition feels smooth, like a plane making a steady, safe landing. Miscalculated, it can result in delayed wake-up or dangerous instability. That handoff from drug support to natural physiology is every bit as critical as induction. What all of this underscores is how misleading the old stereotype really is. The anesthesiologist doesn't step away. They are the only physician in the room trained to watch every life function every second, independent of what the surgeons are focused on. It's a role that demands constant attention and rapid action, not occasional input. Without it, even brief operations would be perilous. Anesthesia is therefore less about pressing a button and more about flying a complex system through shifting conditions. Induction is takeoff, maintenance is the steady mid-flight, and emergence is landing, each phase linked by constant adjustments. Miss those adjustments and the whole system drifts out of its safe zone. Make them well, and the patient passes through the experience unaware, safe, and intact. The ongoing piloting is invisible to patients, but it's the factor that makes anesthesia one of the most controlled aspects of modern surgery. Still, this non-stop oversight is also why patients' greatest anxieties take such strong hold. Because if an anesthesiologist must watch so carefully, people wonder what happens if that balance slips. What if someone does start to wake up? What if awareness breaks through when the body can't move? Those are the stories that tend to haunt people facing surgery, and they remain some of the most vivid fears associated with going under. Anesthesia awareness, the nightmare that hardly ever happens. One of the most unsettling scenarios people imagine with anesthesia is a condition known as anesthesia awareness. This is when a patient, though given drugs to become unconscious and paralyzed, somehow remains aware of events during surgery. They cannot move, cannot signal distress, yet may remember voices or sensations afterward. Stories of this possibility spread quickly because the image is so disturbing. It feels like being locked in place while something urgent is happening around you. The key fact, however, is that in modern operating rooms this outcome is exceedingly rare. For the average, routine surgical patient, the rate of awareness is far less than 1 in 1,000. Most anesthesiologists can complete entire careers without ever seeing a single case in a straightforward procedure. When awareness does occur, it tends to be concentrated in specific higher-risk situations rather than the general population. That contrast is important. For most patients, the black gap of anesthesia is reliable, predictable, and complete. The contexts where awareness is more likely are well-defined. In emergency trauma surgery, doctors sometimes cannot administer full doses of anesthetic because the patient's heart and circulation are too unstable. Heavier medication could push blood pressure fatally low, so lighter dosing is used deliberately, which raises the risk of fragments of consciousness. The same issue appears in open-heart surgery, where circulation is already fragile, and during cesarean deliveries under general anesthesia, where physicians choose careful dosing to limit drug transfer to the baby. In these highly specific conditions, the balance tips toward maintaining safety of mother or circulation, and the risk of awareness rises from extremely rare to measurable. Additionally, patients with significant tolerance to opioids or alcohol sometimes require more anesthetic than average, and if not anticipated, awareness is more likely. These pockets of elevated risk explain why anesthesiologists remain alert to the possibility, even though overall numbers are very low. Understanding what awareness feels like also helps separate myth from reality. The horror image is of a person feeling every cut and unable to scream. In most documented cases, the memory is less dramatic. Patients may recall muffled sounds, voices, or vague impressions of movement or pressure. Actual recall of pain is much rarer, and when it happens, it is usually in the high-risk contexts just described. The fear is visceral because of the loss of agency, being unable to react. Yet the lived experiences, while distressing, much more often involve fragments than full awareness or pain. What keeps today's rates extraordinarily low are several deliberate safety measures. Modern anesthesia includes real-time brain monitoring using EEG or processed signals like BIS, which give anesthesiologists a window into whether cortical activity is staying in the unconscious range. This technology moves beyond the older practice of relying only on heart rate or blood pressure as indirect clues. Drug dosing is also more precise than ever, with a wide range of short-acting agents that can be titrated to effect and stopped quickly if needed. When conditions allow, Anesthesiologists may even limit or skip the use of muscle relaxants, since spontaneous movement provides another natural signal if consciousness begins to return. And in all high-risk cases, practitioners increase vigilance, layering multiple monitors and tailoring drug plans to the individual patient's physiology. These strategies, backed by years of data, are the reason anesthesia awareness has become one of the least likely events in modern surgery. In fact, in the UK's 5th National Audit Project, which reviewed millions of anesthetic cases, confirmed episodes of awareness were extraordinarily scarce, and most took place in the very contexts where lighter anesthesia had been intentionally chosen to protect patients. That evidence has shaped the prevention methods now standard worldwide. Psychological after-effects are another part of why awareness is addressed so seriously. Even if the event involves only sounds or brief impressions, patients can find the lack of control traumatic. Because of that, hospitals put strong emphasis on follow-up. If awareness is suspected, anesthesiologists debrief the patient, provide counseling resources if needed, and record circumstances to improve practice. This supports both recovery and system-wide learning. So why does the possibility of awareness still carry such weight in the public imagination? Because statistics don't erase visceral fears. People rarely picture 1 in a million odds when they imagine surgery. They picture themselves in the worst possible case. The thought of being paralyzed but conscious is so immediate to the imagination that it overwhelms logical reassurances. Media depictions, horror stories, and the spread of anecdotes reinforce that fear. Even though most surgeries conclude with patients astonished at how completely the time vanished, what helps most is reframing. Instead of thinking awareness is a hidden danger lurking in every surgery, it is better understood as a rare complication studied exhaustively and preventable in almost all circumstances. Anesthesiologists anticipate risk factors, monitor continuously, and adapt drug doses for exactly this reason. For routine, elective cases in otherwise healthy people, the odds of experiencing awareness are so low they rival rare environmental risks we never dwell on, such as being struck by lightning. Patients can also help reduce their personal risk by sharing relevant details in advance. Long-term opioid use, high alcohol consumption, or unusual past responses to anesthesia all increase the likelihood of needing higher drug doses. If anesthesiologists know this ahead of time, they can adjust their plans accordingly, often eliminating the hazard. Complete honesty in anesthesia consultations is one of the most practical steps any patient can take. When you view anesthesia awareness with these facts in mind, the subject shifts from nightmare imagery to a controlled, managed medical consideration. It has not disappeared completely, but today's technology, drug options, and training make it one of medicine's rarest adverse events. Most people will never get anywhere near it, and the rare exceptions nearly always happen in contexts where doctors are already weighing life-saving trade-offs. That leaves one final adjustment for patients: separating the power of a scary story from the reality of evidence. The overwhelming likelihood is that anesthesia will deliver exactly what it's designed to provide: a period of no pain, no memory, no awareness, followed by safe return once surgery ends. Your role is simply to provide your team with what they need to plan properly, then allow the monitoring systems and expertise to work as designed. Seen that way, anesthesia awareness is not the shadow it's often imagined to be, but instead a remote possibility that's guarded against at every level. The overwhelming reality is safety, predictability, and the controlled silence of modern anesthesia. What happens afterward, whether you wake up alert or disoriented, is not about awareness at all, but about how your own body processes the drugs and restores itself once the blackout ends. And that recovery phase carries questions of its own, especially why some people wake quickly while others drift in a fog. Why you wake up groggy or fine. Some people come out of anesthesia as if nothing unusual happened. Their eyes open, questions flow naturally, and they seem fully clear within minutes. Others surface slowly, aware but heavy, as if their brain is taking time to reconnect each circuit. These differences aren't random. They are tied to how the body processes anesthetic drugs and how individual physiology, age, surgery length, and medication choices affect the pace of recovery. Clinicians often say that induction, the going under part, is straightforward. The challenge lies in bringing patients back smoothly. Unlike waking from natural sleep, which follows built-in rhythms, emergence from anesthesia depends entirely on drug concentrations falling to levels where brain networks can resume their normal communication. That descent varies from person to person and reflects the balance of pharmacology and biology unique to each body. One of the biggest determinants is drug metabolism. Most anesthetics must be broken down or transformed by the liver, using enzymes that modify molecules into forms the kidneys can excrete safely. Variability in these enzymes, particularly cytochrome P450, CYP systems, plays a central role. For example, some individuals metabolize drugs like propofol relatively quickly, while others take longer. These genetic differences are well documented in research, though they aren't screened routinely in everyday practice. Instead, anesthesiologists anticipate variability through age, medical history, and prior drug response, then tailor dosing in real time. Age itself matters for metabolism speed. Younger patients usually eliminate anesthetics more quickly, thanks to stronger liver and kidney function. Older adults often clear drugs more slowly and are more sensitive to changes in brain rhythms. Many take prescription medications that compete for the same liver enzymes, which can further slow anesthetic breakdown. For these reasons, grogginess after anesthesia is particularly common in older patients, and anesthesiologists plan dosing and drug choices with that expectation in mind. Surgery length adds another factor. Anesthetic drugs accumulate differently depending on how long they are given. Because many of these agents are fat-soluble, they dissolve into fatty tissues during long infusions, then leak back into circulation slowly afterward. That lingering release prolongs recovery. A short 30-minute procedure may leave a patient wide awake within an hour, while a 6-hour operation means more drug storage in tissue and a slower ride back to full alertness. This context-sensitive recovery explains why people who undergo longer operations often feel clouded even into the next day. Half-life also shapes return to clarity. Every anesthetic drug has an expected time for its level to have in the bloodstream. In 2025, many commonly used agents have been engineered with short half-lives. Remifentanil, for example, is metabolized within minutes. Still, half-life values remain only averages. Individual differences in liver enzyme activity, kidney clearance, and tissue absorption mean real-world wake-up times don't always match textbook numbers. To illustrate the variability, think of a computer reboot. Sometimes it restarts and is instantly responsive. Other times, familiar icons appear slowly, one window at a time, until the system feels usable again. Recovery from anesthesia works much the same way. Networks in the brain must reconnect. For some people, synchronization is rapid and smooth. For others, it flickers and stabilizes more slowly, creating that groggy, heavy-headed feeling. Drug selection also strongly influences recovery. Propofol, delivered intravenously, is short-acting and clears quickly. Inhaled agents like sevoflurane and desflurane tend to linger longer, though they too are designed for relatively fast offset. Muscle relaxants, opioids, and sedatives administered during surgery all contribute to how extended the fog feels, because each adds its own pharmacologic drag on alertness. The anesthesiologist balances those drugs not just for surgical stability, but also to optimize how clear a patient will feel in recovery. Beyond drugs, the surgery itself plays a role. Operations disrupt physiology through fluid shifts, blood loss, tissue injury, and sometimes temperature changes. These stresses tax the body, creating fatigue even once anesthetics are resolved. That means a patient may still feel drained, not because of anesthetic molecules, but because recovery requires cellular repair and rebalancing. Grogginess after surgery reflects not only drug clearance, but also how strenuously the body was challenged. Recent strategies have aimed to speed clearer recovery. Many hospitals now use multimodal pain control, combining regional anesthesia with non-opioid medications to reduce reliance on opioids during and after surgery. By minimizing opioid use, patients regain sharper awareness earlier and avoid prolonged sedation. Regional blocks, such as nerve blocks or epidurals, can provide strong localized pain relief, reducing the need for heavier systemic drug. This approach is one of the clearest ways modern practice has shortened groggy wake-up times. Anesthesiologists also work proactively based on what they know about a given patient. A thorough preoperative assessment often reveals whether someone is likely to metabolize drugs slowly or face more prolonged emergence. In those cases, clinicians may choose agents with especially short half-lives or avoid giving larger doses late in surgery. These adjustments mean recovery time, while still variable, is seldom a complete surprise to the team. From the patient's perspective, it can feel random. You either wake up quickly and clearly or take longer to reconnect. In reality, many factors intertwine: genetics shaping enzyme activity, age influencing organ function, the kind and length of the procedure, the drug formulations used, and the body's overall resilience. What feels like chance is actually the sum of predictable influences integrated into an individualized anesthesia plan. This is why stories from different patients can sound so different. One person recalls waking up in recovery talking casually within minutes. Another remembers the fog lasting for hours. Both experiences are normal outcomes of the same process, filtered through very different bodies and surgical contexts. What remains constant is that anesthesiologists anticipate the variability, monitor continuously, and intervene when needed to guide a safe, predictable return. Individual differences in wake-up speed will always exist, but they are not left unmanaged. Anesthesia in 2025 is less about guessing and more about tailoring. Years of pharmacology advancements, careful pre-op planning, and the integration of EEG monitoring have made it possible to match anesthetic depth to patient physiology in real time and adjust how recovery unfolds. For patients, that means whether emergence feels sharp or sluggish. It is part of a managed transition rather than a gamble, and that confidence that your recovery has been shaped deliberately long before you open your eyes is one of the most important reassurances in modern anesthesia. Yet safe waking doesn't depend only on drug clearance and how your body handles molecules. Another crucial safeguard in anesthesia begins hours before you ever step into the operating room, long before the first drug is even given. It starts with a simple but strict instruction every patient knows well and many question in frustration: the rule about avoiding food and drink before surgery. Eating before surgery. The rule with serious consequences. Eating or drinking before surgery isn't just a minor issue, it directly affects safety under anesthesia. The reason fasting is required is simple. When anesthetic drugs take effect, the muscles that normally protect your airway stop working. Reflexes like coughing, swallowing, and gagging disappear. If your stomach still contains food or liquid, that material can come back up and slip into the lungs without warning. This is called pulmonary aspiration. When it happens, the acidic contents of the stomach can burn delicate tissues in the airway and lungs, block oxygen exchange, and trigger serious infections. For anesthesiologists, preventing aspiration is one of the most important responsibilities of the entire procedure. Outside of anesthesia, eating and drinking are safe because your muscles guide food into the esophagus and keep it from entering the windpipe. You can cough material away if something feels wrong, but once you're anesthetized, that protection is gone. If stomach contents reach the lungs, the consequences are immediate and dangerous. Even a small amount of regurgitated acid can cause chemical pneumonitis, essentially a severe chemical burn in lung tissue. Solid food particles create an even greater hazard, physically blocking small airways or introducing bacteria deep into the lungs. Because patients under anesthesia cannot respond, the anesthesiologist may have no clue aspiration is happening until the damage is already done. That's why the safest course is to begin surgery with an empty stomach. For decades, the rule was nothing by mouth after midnight, no matter what time surgery was scheduled. By 2025, research has refined that approach. Instead of one rigid standard for everyone, fasting guidelines now carefully distinguish between types of intake. Solid food, especially meals rich in protein, fat, or fiber, takes many hours to leave the stomach. That is why most current protocols set a 6 to 8 hour fasting requirement for solids, including snacks. Heavy meals sometimes need the full 8 hours to clear safely. By contrast, clear liquids such as water, electrolyte solutions, or apple juice leave the stomach quickly. Studies show they are gone within 2 hours for most people. For that reason, modern guidelines often allow patients to continue drinking small amounts of clear fluids up to 2 hours before anesthesia. This shift makes a big difference for patients. Long fasting periods can cause dehydration, headaches, and irritability, which only add stress before surgery. Allowing clear liquids until 2 hours prior helps prevent those problems without reducing safety. The rules are crafted not from tradition, but from evidence about how long the stomach takes to empty. That evidence tells us that solids and fatty meals need much more time to clear than transparent fluids. By separating the rules for these categories, anesthesia teams can protect patients while minimizing discomfort. The details matter. A clear liquid really means a liquid with no fat, pulp, or protein that leaves no residue. Water, clear juices without pulp, and electrolyte solutions qualify. Coffee with milk or cream does not. It contains fat and protein that slow gastric emptying. Similarly, even just one cracker still counts as a solid food. Once swallowed, it must undergo digestion like any other carbohydrate. The body does not make exceptions for small amounts, and neither can anesthesiologists. The guideline is binary. Your stomach is empty, or it is. A sip of water 2 hours before surgery may be recommended. A sip of coffee with milk may be enough to delay or cancel the procedure. In children, fasting rules adjust slightly. Pediatric patients follow the same physiology, but their digestion differs in speed. Breast milk, for example, empties from the stomach faster than infant formula. Standard recommendations often permit breast milk until 4 hours before anesthesia, while formula generally requires 6 hours. Clear liquids remain permissible until 2 hours before. Solid food follows the same 6 to 8 hour cutoff. Parents may struggle with this, especially managing a hungry or thirsty child before an early procedure. But the risk of aspiration is just as real in children as in adults. These timelines represent the safest balance between comfort and protection in young patients. Sometimes patients hope there will be a workaround if they've eaten by mistake. Unfortunately, there is. If you forget and have solid food within the fasting window, anesthesia becomes a calculated risk with the potential for catastrophic complications. In these cases, the safest option is nearly always to delay surgery. Canceling may feel inconvenient or frustrating, but the alternative puts you at substantially higher risk of aspiration under anesthesia. Surgeons and anesthesiologists may appear stern about this point, but the motive is never punishment. It is prevention, and it protects you in the most direct way imaginable. Compliance with fasting instructions also gives the anesthesia team confidence during surgery. When they know the stomach is empty, their focus can remain on managing anesthesia depth, circulation, pain control, and recovery. If there's uncertainty about recent food intake, every step carries needless added risk. That is why fasting is not optional or negotiable. It is one of the simplest yet most critical safeguards in anesthetic care. It is also essential to recognize that while broad guidelines exist, each hospital may adjust specifics based on local protocols or patient populations. Some centers may have slightly different cutoffs for children or revised recommendations for clear carbohydrates before surgery. This variability is not contradiction. It reflects refinement of practice based on the best evidence and clinical judgment. For patients, the best approach is straightforward. Follow the exact instructions given by your care team. They reflect the latest knowledge about how to keep the procedure safe where you are being treated. The physiology behind fasting rules is unforgiving. The stomach does not clear faster because a procedure feels minor. Even if you feel hungry enough to believe your stomach is empty, small amounts of food or liquid may still remain. Imaging and research show that gastric emptying is invisible to personal perception. That is why personal judgment is not a substitute for standardized fasting instruction. Only time guarantees emptying, and only adherence protects the airway when anesthesia silences reflexes. Seen in this light, fasting before surgery is not a discomfort imposed for tradition's sake, but a proven intervention against a preventable catastrophe. It reduces the odds of pulmonary aspiration, one of the most dangerous threats in anesthesia, to near zero in healthy patients. Giving up solid food the night before and clear liquids a few hours before surgery may feel strict, but compared to the risk of acid and food entering the lungs, the trade is straightforward. For the patient, this is one area in anesthesia where safety rests almost entirely on cooperation. The anesthesiologist controls your breathing, circulation, and state of consciousness, but only you can control what is in your stomach when anesthesia starts. That partnership between provider vigilance and patient preparation creates the conditions for the smooth, uneventful experience most people have every day in operating rooms worldwide. So when those fasting instructions arrive, think of them not as a burden, but as the first critical step in anesthesia safety. Following them is what allows every other safeguard to work properly. You may feel uncomfortable for a few hours, but what you avoid is the single complication every anesthesiologist hopes never to face. And while the rules about eating and drinking may surprise patients who expected something simpler, they are nothing compared to another source of misunderstanding. Much of what people think they know about anesthesia doesn't come from doctors at all. It comes from movies. Those Hollywood versions look dramatic, but have little to do with what actually happens in an operating room. Myth-busting movie anesthesia. If your impression of anesthesia comes from film and television, you've probably seen a character drop unconscious the instant a syringe touches their arm or after one dramatic inhale through a mask. The effect looks cinematic, sudden, absolute, and perfect for heightening tension. But while these split-second collapses play well on screen, they misrepresent how anesthetic drugs actually work in the body. Real anesthesia is fast, but never instantaneous in the way fiction suggests. Start with the injection trope. In countless action or medical dramas, a jab in the neck sends someone crumpling to the ground in a fraction of a second. That's not how intravenous anesthetics behave. Even the quickest agents, such as propofol, need at least several seconds to circulate through the bloodstream, travel to the brain, and reach the concentration needed to switch off awareness. In most patients, that transition happens within 20 to 40 seconds. To the outside observer, it looks rapid, but to the anesthesiologist guiding the process, those seconds are essential. They allow time to oxygenate, support breathing, and monitor circulation. Reality is more like someone fading into heavy drowsiness than switching off like a lamp. Inhaling anesthetic gases follows the same principle. On screen, a mask slams down and one gasp later the character is unconscious. In actual operating rooms, inhaled induction takes more than a single breath. The patient needs repeated deep respirations while a concentration of gas builds in the lungs, enters the bloodstream, and moves to the brain. This usually takes a minute or two, sometimes a little longer in adults. It doesn't deliver theatrical collapse, but it does allow anesthesiologists to adjust flow rates, check vital signs, and confirm that each step is progressing safely. The speed of induction in real practice is therefore fast but controlled. That controllability matters as much as the drugs themselves. If it were possible to produce total unconsciousness in a single heartbeat, it would actually be unsafe. The anesthesiologist would have no time to support the airway, monitor circulation, or titrate the effect. Instantaneous profound suppression may look clean on screen, but in reality, it would remove the safety window needed for human oversight. Modern monitoring standards and decades of research stress the importance of managing anesthesia as a gradated process, not a blunt knockout. Speed in real medicine must always be paired with control. Hollywood also simplifies the dosing. In most stories, one injection works universally, whether the subject is a child, an athletic adult, or someone with complex medical conditions. Biological reality is far more complicated. Drug requirements vary by age, body composition, metabolic rate, and even history of alcohol or opioid use. A person with chronic exposure to sedative substances may need significantly larger doses than someone naive to them, while elderly patients often require much smaller doses to avoid dangerous suppression. Children metabolize anesthetics faster and therefore need adjustments tailored specifically to them. These factors underscore why anesthesia is never standardized to one shot fits all. Another staple of movie anesthesia is permanence. In film, once unconscious, characters remain out until they're jolted awake by a second magic drug hours later. That's not how actual anesthesia works. A single dose only provides unconsciousness for a short time, often just minutes. To keep someone anesthetized through an entire operation, drugs must be continuously supplied by infusion pumps in the IV line or carefully inhaled gases delivered through a ventilator. Stop the supply, and the body immediately begins metabolizing and clearing the agents, allowing the brain to reconnect its circuits and gradually restore consciousness. The idea of out indefinitely until reversed is fiction. Continuous management is required at every stage. This difference between fantasy and reality matters for patients who worry about giving up control. Movies often portray anesthesia as a violent blackout, where consciousness is ripped away without warning. In operating rooms, the progression is quieter and more gradual. You might feel your speech slowing, your mind drifting, your eyes closing. An anesthesiologist is constantly checking your status during these moments, balancing medications not just for unconsciousness, but also for breathing, blood pressure, and pain control. It's a transition that happens smoothly, not chaotically. The myths also create misplaced fears. Because movies show anesthesia as a dramatic knockout, some patients arrive expecting a similar shock. In real life, induction tends to feel calm, sometimes even anticlimactic. You may hear an instruction to take slow breaths or answer a simple question, and then memory ends. What sticks is not panic or pain, it's a gap in time. Patients who expect the violent collapse of film are often surprised by how uneventful the actual process feels. It's worth emphasizing that the so-called boring reality is what makes anesthesia one of the safest fields in modern medicine. Medications are chosen precisely because their effects can be adjusted, paused, or reversed. Each small window of time while the drug takes effect gives clinicians the opportunity to monitor and adapt. The flexibility to titrate effects for the individual patient, for the specific surgery, for the current condition, creates safety margins that instantaneous blackout would erase. Rule of thumb: in real medicine, speed must be controllable to be safe. Without constant adjustment, anesthesia would not work the way we rely on it today. The image of a syringe or mask acting like a power button ignores the meticulous process running underneath. Every surgery involves assessing depth of unconsciousness, fine-tuning drug levels, and supporting vital functions for as long as the operation continues. A 1-second collapse may be more thrilling on screen, but it has nothing to do with how millions of patients safely undergo anesthesia around the world each year. So when films show the dramatic sag of a head after one gulp of anesthetic gas or the instant collapse from a jab in the arm, remember that it's storytelling shorthand, not physiology. Actual anesthesia requires carefully measured drugs that wash through the system over seconds to minutes, guided by specialists who monitor every variable to keep you stable. The sharp takeaway is this: cinema makes anesthesia look simple and sudden, but in reality it is deliberate and finely titrated. That difference between fiction and practice is what ensures patients stay safe. And if movie versions oversimplify the process for drama, what's happening now in real operating rooms is far more interesting. The fact that modern anesthesia is not only safe, but evolving rapidly with new drugs and smarter tools designed to make recovery easier than ever. The 2025 secret: new drugs and smarter recovery. You've heard the familiar parts of anesthesia for years. The safety figures, the standard routines, the sense of drifting off into nothing and re-emerging in recovery. What most patients don't hear is how much the field has shifted in 2025. This isn't just anesthesia as it's always been, it's the refinement of recovery itself. The newest developments are aimed not only at keeping you unconscious and pain-free during surgery, but also at controlling how clear, stable, and comfortable you feel afterward. The biggest change most patients notice is how much quicker the haze clears. In the past, inhaled gases like halothane or even earlier versions of sevoflurane and isoflurane could linger in fat and muscle. That meant heavier grogginess, dizziness, and nausea that sometimes stretched into the day. In contrast, today's practice leans heavily on short-acting intravenous agents. Propofol has long been a mainstay, but refinements in drug delivery and formulation have made it even more predictable. On the pain side, ultra-short opioids such as remifentanil are widely used because they wear off within minutes once the infusion stops, leaving fewer lingering side effects. Patients describe waking clearer, able to follow questions quickly, and less likely to need repeated interventions for nausea. This evolution is often called fast-track anesthesia, and it represents a deliberate change in priorities. Safety during surgery is no longer the only measure of effectiveness. Recovery quality is treated as just as important. Anesthesiologists now aim to provide just enough anesthetic depth to cover each moment of a procedure and then taper it away smoothly to minimize residue after surgery ends. When protocols are carefully matched, patients often stand out as being alert and oriented in the post-anesthesia care unit within minutes, not hours. Faster discharge from recovery rooms follows naturally, saving patients stress and hospitals resources. Precision dosing has also changed the landscape. For decades, anesthesia calculations focused on weight, adjusted along the way by observing heart rate, blood pressure, or movement. That model still works, but it relies on constant fine-tuning by humans using indirect signals. In 2025, many centers are piloting the use of advanced dosing software and target-controlled infusion systems. These rely on pharmacokinetic models refined with large datasets, and in some cases AI systems that watch how drug levels synchronize with a patient's physiology. Variables such as age, sex, medical history, and individual responses in the first few minutes are integrated in real time. The goal is tighter control, enough medication to avoid awareness without overdosing, and a gradual taper that aligns with the conclusion of surgery. For the patient, these upgrades show up in two key ways. First, the risk of going too deep, leading to prolonged grogginess, or too light, risking awareness, shrinks considerably. Second, recovery is smoother because dosing adjustments anticipate how long a drug will take to leave the body instead of relying on rough averages. It means the moment the surgeon finishes, the anesthesiologist has already been guiding your medications toward a safe and timely emergence. Another noticeable benefit is the reduction in common side effects. Nausea and vomiting, once so common they seemed inevitable, are now far less frequent. Short-acting agents reduce exposure, and predictive modeling allows anesthesiologists to tailor anti-nausea medications to patients who need them most. Recovery rooms are quieter for it. Fewer people clutching emesis bags, fewer delays before discharge. What was once accepted as part of the price of surgery is now seen as preventable. Genetics and pharmacogenomics add another layer, though not yet universally adopted. Some people carry enzyme variants that affect how quickly they metabolize anesthetics or opioids. Variations in CYP450 enzymes, for instance, can make a standard dose act either too strongly or too weakly. Until recently, this meant two identical patients given the same drug regimen could have very different recovery profiles. In 2025, pharmacogenomic insights are starting to be incorporated where information is already available, particularly for patients with documented enzyme polymorphisms or complex medical histories. These tools aren't yet routine everywhere, but they're emerging as a way to individualize anesthesia plans. For patients, it means recovery feels smoother and more predictable because drug selection and dosing are informed in advance rather than solved only in hindsight. Closed-loop and AI-assisted dosing represents another frontier. Trials have shown that automated systems can adjust drug infusions based on processed EEG signals, keeping brain activity within a therapeutic range. Early results suggest these systems can hold anesthetic depth steady with fewer swings than manual adjustment alone. Yet human oversight remains essential. Anesthesiologists supervise, decide, and intervene. Automation is a supplement, not a replacement. What matters is that these advances free clinicians to anticipate transitions while still controlling the big picture. Some of the most practical improvements appear at the end of surgery. In the past, patients often had to wait out the lingering presence of drugs as the body metabolized them. Now, newer reversal agents allow anesthesiologists to end the effects of certain medications instantly, rather than waiting for drug levels to fall naturally. If a neuromuscular blocker was used, it can be counteracted quickly, ensuring breathing and movement recover on time. If opioids remain in the system, antagonists can clear their sedating effects while still leaving pain control in place through other drugs. These changes make emergence less of a waiting game and more of a managed descent. Recovery protocols also reflect this shift. Instead of simply watching monitors until the fog lifts, anesthesiologists actively test awareness and coordination soon after surgery. Patients may be asked to squeeze a hand, track a moving object, or answer simple questions. With the newer short-acting drugs, these tests can be completed reliably just minutes after anesthesia ends. That means discharge decisions are better tailored to each patient's genuine recovery status, not mere clock time. The broader benefit of these refinements is easy for patients to appreciate. Shorter stays in the recovery room, fewer complications afterward, and a clearer head when reconnecting with family. For hospitals, it reduces congestion, cuts costs, and allows schedules to move more efficiently. For patients, it replaces hours of grogginess with faster return to normal function. Not every surgery uses the shortest possible anesthetic regimen. Major, prolonged procedures still require heavier approaches and longer-acting drugs for stability, but the ability to combine them with targeted reversal agents and careful monitoring still improves how patients wake compared to decades past. The guiding principle is no longer just keep them unconscious until it's over. It's stabilize, protect, and return them quickly to clarity with as little residue as possible. The story of anesthesia in 2025 is one of precision and personalization. Faster clearing drugs like remifentanil, refined propofol use, and target-controlled systems allow a blackout that is carefully sculpted. AI support and pharmacogenomic insights aren't universal yet, but they point toward a future where anesthesia plans are customized from the first minute. Automated titration, where available, keeps patients in more stable ranges, and modern recovery protocols minimize side effects and shorten time spent in the post-op unit. Patients may only notice that they feel less groggy, experience less nausea, and leave the hospital sooner. But underneath that experience lies the deliberate redesign of nearly every stage of the anesthetic. It is still a blackout, but one engineered to end quickly, clearly, and safely. And that evolution leads to an even bigger realization, not about one drug or one machine, but about the entire concept of anesthesia itself. What happens in the operating room is not sleep, not a puff of knockout gas, and not a mysterious fog. It is one of the most precise states of consciousness humans have learned to control. Anesthesia today is best understood as a reversible, highly monitored medical state engineered to block pain, memory, and movement so surgery can be performed safely. Surgeons repair the body, but anesthesiologists guide you through that suspended state, ensuring every function is supported until it is safe to wake. What feels like a blank gap to the patient is a carefully staged process overseen second by second. Your role is to help that process by sharing any health concerns beforehand, such as sleep apnea, medications, or prior anesthesia reactions, so your team can plan effectively. And to you, what's your biggest question or fear about anesthesia? Share it below.